morning, students. This is Dr. Herndon. I am recording your Chapter 24 lecture for you, and this is for the concepts of care for patients with non-infectious lower respiratory conditions. We're going to be in Chapter 24 of Iggy, as well as McKinney for the respiratory piece in McKinney, and ATI, Pediatric and Med-Surg. We will cover only the 3 areas of COPD, asthma, and RSV. You'll have cystic fibrosis during the summer with Miss Britt in pediatrics, and then you'll cover lung cancer and nursing 212 in the fall semester when you go into your full second year in that semester there. So asthma is described as a chronic disease in which acute reversible airway obstruction occurs intermittently, reducing the airflow, and chronic obstructive pulmonary disease is described as a collection of lower airway disorders that interfere with airflow and gas exchange. And my mother-in-law actually passed away because she had pulmonary fibrosis. So that is one disease that's under the umbrella of COPD, and that was very scary. And she, she didn't, she wasn't that ill until the very end, but after she was diagnosed, it did get worse, and she passed away within 3 to 4 years of her diagnosis. So it's very scary. Now RSV is a respiratory syncytial virus and negatively affects young children and possibly older adults with symptoms of lung infection and difficulty breathing and lethargy, fever, mucus production, and just a decrease in oxygen saturation. And so it's very scary for the very young, but the very older segment of society may be affected pretty seriously as well. So it's very common. This RSV is very common. We may have it as adults and think it's just a cold or just a minor ailment, but we can take it to young children if we're not careful. So we are not as affected as the very young children, but we carry it, as I said, we can carry it to very young babies, and it's important to recognize that. Okay, so again, the primary focus in this chapter is gas exchange, and this also is interrelated to perfusion and inflammation as well as cellular regulation. And as you recall, the lower respiratory tract is a tubular system of the trachea, and then 2 main stem bronchi, and then 5 secondary bronchi, and then thousands of branching bronchi and bronchioles, and the alveolar ducts that connect to the alveoli. So, so it's like it looks like a tree that's branching out, but the alveoli is where the gas exchange occurs in the lungs, and when the function of any of these structures is reduced, both the gas exchange and the systemic perfusion are very much impaired. So many of the lower airway problems are chronic and progressive, and that requires changes in lifestyle sometimes, and especially for the older adults. And as we age, changes occur within the pulmonary system, and these changes increase the risk of pulmonary disease and infection. Please pay attention to the pink box on the bottom left side of page 540 that speaks to nursing accommodations for an older adult with a respiratory problem. That's very important for you to pay attention to that. And as I said, asthma is one of the most common lower respiratory disorders that reduces gas exchange. It can lead to severe airway obstruction and death. Asthma is a chronic disease in which reversible acute airway obstruction occurs intermittently and reduces airflow. Airway obstruction occurs by both inflammation and airway tissue sensitivity and causes bronchoconstriction. Inflammation obstructs the airway lumens, and airway hyperresponsiveness and constriction of the bronchial smooth muscles, it narrows the tubular structure of the airways. The inflammation and sensitivity can trigger bronchial constriction, and many adults suffer from asthma. We think of asthma as being a child's disease, but asthma actually causes approximately 3,500 deaths each year in the United States. I did know a couple with a child. The child was my son's age at the time, or close to my son's age at the time, and they were in some activities together. And the father of the child had asthma and was working really hard and came in contact with some irritants and ended up in the hospital with asthma, with his asthma, and he was very hypersensitive to certain irritants and environmental things in the environment that were triggers for him, and he actually ended up passing away. And the child was and the mother, I mean the wife and the child, they were devastated. It was very highly unexpected. It was not expected at all, and it was just really hard. And so we didn't expect him to pass away from the asthma, but once asthma is exacerbated and we it seems to, if it gets to a certain point, it gets to a point where you can't get the body to back down from the inflammation and from the constriction of the bronchioles and the the airway. So it can be a scenario where we have status asthmaticus, and that is a very severe form of asthma attack. It's a severe form of an asthma attack, and it can lead to death. So we'll talk about that. But just remember the asthma is not, it's very important to uh, control the symptoms and also have a rescue medication on board. Some of the medications that control the asthma are taken every day, regardless of what symptoms the person is having. And then there are rescue drugs that bring the person back uh, from the asthma attack to where they can breathe normally. So we'll talk about all of those medications, and I've actually made a grid of the medications for you that's on the LMS that you can study from. It's in your book too, but I just put it in a grid so that you can have it, in a sheet of paper that you can work with easily, I hope. Asthma can be classified into types based upon what triggers the attacks, but the effect on the gas exchange for asthma is the same. It is inflammation of the mucous membrane lining in the airway, and it is a key event in triggering um, an asthma attack. So that inflammation is the key event that triggers the asthma attack. So with asthma, there's a chronic airway inflammation which causes bronchial hyperresponsiveness and airway constriction. And this increased airway sensitivity, hyperresponsiveness can occur with exercise or upper respiratory illnesses, as well as for unknown reasons. But it is important that people with asthma know their triggers. Um, Asthma can be triggered by different types of white blood cells within the epithelial lining of the lower respiratory tract. For some people, an overabundance of eosinophils make these airways hyperresponsive, and this is known as eosinophilic asthma. And then interleukin 5 is a major mediator that activates the eosinophils, which increases inflammation and leads to an asthma attack. And this type of asthma accounts for about half or 50% of all asthma cases. Neurotrophic, neurotrophic asthma is the second type of asthma, and that is brought on by white blood cells, and the neutrophil response to the asthma triggers and is mediated by the interleukin 17. So the symptoms are the same in both of these types of uh, asthma that is triggered by the different types of white blood cells. But the long-term effects differ in terms of the effects of the respiratory epithelium. Additionally, some drugs are more specific for one type of asthma than the other. So we'll continue our study, and we'll continue to learn. Genetic studies have identified more than 100 genes that may play a role in susceptibility and development and treatment response of asthma. So that's exciting that we're learning all of this. When asthma is well controlled, airway changes are temporary and reversible. With poor control, chronic inflammation leads to airway damage and altered cellular regulation with enlargement of the bronchial epithelial cells, and mucus secreting cells that change in the bronchial smooth muscles. And with frequent asthma attacks, even exposure to low levels of the triggering agent or event may stimulate an attack. So it's important to, have asthma well controlled. Inflammation triggers asthma for some adults when allergens bind to specific antibodies, especially the immunoglobulin E or IgE, and these antibodies are attached to tissue mast cells and the white blood cells, including basophils, eosinophils, and neutrophils, which are filled with chemicals that can start local inflammatory responses. Some chemicals, such as histamine, start an immediate inflammatory response, which can be blocked by drugs such as Benadryl or diphenhydramine. So other chemicals such as leukotrienes are slower and cause later and prolonged inflammatory responses, which can be blocked by drugs such as montelukast or Zafirlukast and Xyluten. And chemicals also attract more white blood cells to the area, which then continue the responses of blood vessel dilation and capillary leak. And this causes mucous membrane swelling and increased production of mucus. And when this happens, the lumens narrow more, which interferes with airflow and gas exchange. Bronchospasm is the narrowing of the bronchial tubes by constriction of the smooth muscles around and within the bronchial walls, and it can occur when small amounts of pollutants or respiratory viruses stimulate nerve fibers and cause a constriction of bronchial smooth muscle. If an inflammatory response is stimulated at the same time, the chemicals released during inflammation also trigger constriction. Severe bronchospasms can profoundly limit gas exchange. Aspirin and other NSAIDs can trigger asthma in some results, which results from increased production of leukotriene when the aspirin or NSAIDs suppress other pathways of inflammatory mediator production. So gastroesophageal reflux disease, or GERD as we know it, can trigger asthma in some adults and cause asthma symptoms at night. When that GERD usually acts up is at night, when you've eaten maybe a heavy meal before you go to bed at night. With GERD, it is usually recommended that folks eat early and not eat anything right before they go to bed. But with GERD, acidic stomach contents enter the airway and make pre-existing tissue sensitivity worse. So this is just another thing that causes the irritation and can be a trigger. Okay, so asthma can occur at any age. 50% of adults with asthma had asthma as a child. I had asthma as a child. I don't think I've had asthma as an adult yet, but it could happen. So asthma affects over 20 million adults in the United States. Over 4 million adults ages 65 and older have asthma. And because lung and airway changes as a part of aging, this makes breathing problems more serious in the older adult. Asthma-related deaths are highest in adults over 65 years of age. And by the way, the man that I mentioned earlier that passed away that had the younger son, I think his son was 10 at the time. He was young. He was in his 30s. So, and he was a big, healthy guy. So, you can't always say that, all of the people who have asthma-related deaths are over 65. But anyway, just want to point that out. Another problem related to aging is a decrease in the sensitivity of beta adrenergic receptors, and when stimulated, these receptors relax smooth muscles and cause bronchodilation. When these receptors become less sensitive, they no longer respond as quickly or as strongly to agonists and beta adrenergic drugs, which are often used as rescue therapy during an acute asthma attack. So these drugs no longer, will work as well for the older adult. So they have less impact on the older adult. So these rescue drugs do. So it's good to talk to it's good to confer or collaborate with a physician um, and advocate for your patients in this matter. So teaching older adults how to avoid asthma attacks and how to use preventive drug therapy is your priority as a nurse. As a treatable chronic disorder, asthma is generally managed in the community with healthcare oversight. Acute exacerbations may require management in emergency departments or ICUs. Because asthma is a common disorder, adults admitted to the hospital for other health problems or surgery may also have asthma. And for optimal control, continuing the asthma management plan, including drug therapy, is the priority. So again, I've put the drugs that are in this module, in this chapter, chapter 24, in a grid for you, and you can download it and print it, but just be certain that you study these drugs and that you know these drugs. So asthma is classified on the basis of how well controlled the symptoms are based uh, on a consistent basis as defined by the Global Initiative for Asthma. And you can see box 24.1 for key features and control levels. And as far as history, the patient with asthma usually has a pattern of episodes of dyspnea, chest tightness, coughing, wheezing, and increased production of mucus. And we need to know if these symptoms are continuous, if they're seasonal, related to specific activities. Maybe they're soccer players or, they play tennis or whatever it is they play, or um, are active in their activity. Make sure that we know what the triggers are and when it happens. Maybe exposures at work, more frequently at night, etc. So when does it happen? When it happens. And the patient with atopic or allergic asthma may also have other allergy problems. And we also need to look at whether or not they smoke, or does anyone smoke in the house? Are they around anyone that smokes? Because cigarette smoke, that's a common trigger. Also, your physical assessments. The patient with mild to moderate asthma may have no symptoms between asthma attacks. During an acute episode, the symptoms will be wheezing and increased respiratory rate. Initially, wheezing is louder upon exhalation, and when inflammation increases, coughing will increase. With worsening, the patient will use accessory muscles to breathe during an attack. So you need to, as a nurse, you need to look for muscle retraction at the sternum and the suprasternal notch and between the ribs. So this is where you look at whether or not they're using accessory muscles. And the patient with long-standing and severe asthma may have a barrel chest that has been caused by air trapping in the lungs. And the anterior-posterior, or the AP diameter, will increase with air trapping, and it gives that chest a rounded look rather than an oval shape. And the normal chest is 1.5 times as wide as it is deep. With severe chronic asthma, that AP diameter may equal or exceed the lateral diameter. So that's going to be something that you're going to notice as a nurse. And the chronic air trapping um, will flatten the diaphragm and increase the space between the ribs. So there will be audible wheezing. The breathing cycle will be longer and prolonged. Exhalation will, and it will require more effort. The patient may be unable to speak more than a few words between breaths. Hypoxia occurs in severe asthma. The oral mucosa and nail beds will be cyanotic or have a bluish tinge, and changes in cognition or consciousness and tachycardia may also be present. So all of these symptoms you will look for. The lab assessment, lab tests can determine asthma types and the degree of breathing impairment. The arterial blood gas, or the ABG levels, show effectiveness of gas exchange. The arterial oxygen level, or the PaO2, may decrease during asthma attacks, and early in the attack, arterial carbon dioxide levels, or PaCO2, they may be decreased as the patient increases the breathing rate and depth. And later in the episode, the PaCO2 rises, as does the end-tidal carbon dioxide level, indicating carbon dioxide retention. Allergic asthma often occurs with elevated serum eosinophil counts and immunoglobulin E, IgE levels, and the sputum may contain eosinophils and mucus plug with shed epithelial cells, and this is known as the Kirschmann spirals. Your pulmonary function tests, those are the most accurate tests for measuring airflow in asthma, and they're the pulmonary. This is done using the pulmonary function test spirometry, and baseline PFTs are obtained for all patients diagnosed with asthma. The most important PFT are forced vital capacity, the FVC, and the forced expiratory volume in the first second, that's your FEV1, and the peak expiratory flow, the PEF, and sometimes this is called a peak expiratory rate flow, and that's called the PERF, or the PERF. If you've never had asthma, or you've never known anybody with asthma, or you've never had a patient with asthma, you probably are not familiar with these terms, and it's going to take a little bit of time to get your head around it, but it will become second nature to you as you work with asthma patients. So the definitions of PFTs are listed on Chapter 22. Asthma is diagnosed when these values increase by 12% or more after treatment with bronchodilators. And airway responsiveness is tested by measuring the PEF and the FEV1 before and after the patient inhales the drug methacholine, which induces bronchospasms in susceptible adults. And so, the purposes of asthma therapy are, of course, to control and prevent episodes and improve airflow and gas exchange and to relieve the symptoms. And asthma is best controlled when the patient is an active partner in the plan for management of asthma. The primary nursing actions focus on patient education related to the control plan for asthma. Self-management education, this is uh, asthma often has intermittent overt symptoms, and with guided self-care, patients can co-manage the disease, increasing the symptom-free periods and decreasing the number of severity of attacks. Good management decreases hospital admissions and increases participation in patient-chosen work and leisure activities. So self-care requires extensive education for the patient to be able to monitor respiratory status and recognize their symptoms and manage and adjust medications based on their symptoms. Self-care includes the knowledge of when to consult the healthcare provider or to seek emergency care. So in saying all of this, you know what you need to teach your patient, or make certain that they do know, and fill in what they don't know. So the action plan for asthma is developed by the primary care provider and the patient, and it's tailored to avoid the patient's triggers, manage asthma symptoms and drug responses. And the plan includes a prescribed controller drug schedule, a patient-specific daily asthma control assessment questions, and directions for adjusting the daily controller drug schedule. So when to contact the provider in addition to regularly scheduled visits is important, and emergency actions to take when not responding to controller and reliever drugs. And then the patient needs to keep a track of symptoms and actions necessary when managing their asthma and the peak flow monitoring. So that's important. And patients patients should self-monitor peak flow measurements when experiencing an exacerbation after a change in treatment and when measuring a response to treatment or when symptoms appear to be more severe or excessive. And the patient should keep a daily diary, excuse me, or daily a diary of symptoms and intervention. So they need to something that they can go back and look at. Well, what happened here, and how long has this been going on? Because you do, you know, you need that record so that you can track trend. Um, and then the drug therapy box 24/2 for management, pharmacologic management of adults with asthma, and the step therapy, that's very important. So avoid triggers, avoid drugs that trigger asthma, avoid foods with MSG. Use meds 30 minutes prior to exercise. And if trigger includes exercise, we need to use the metered dose inhalers correctly, get adequate rest and sleep, reduce stress and anxiety, use relaxation techniques and coping mechanisms, and wash all bedding with hot water to destroy dust mites, because most people are allergic to dust mites. Um, we need to make sure they seek emergency care with gray or blue fingertips or lips. That's important, that cyanosis is, that they know what that means and they know what to check for. And if they're dark-skinned individuals, they need to look in the buccal membrane, the mouth, and the side of the cheek. So also when they're having difficulty breathing, when they're having difficulty walking or talking, retractions in the neck, that's a sign. Retractions in the chest or ribs, nasal flaring is a sign. Also, failure of drugs to control worsening symptoms. So all of this is very important. And then we have control therapy. Um, this is used to reduce the airway sensitivity or responsiveness to prevent asthma attacks from occurring and maintain the gas exchange. These are used every day. As I said earlier, The control therapy is used every single day, regardless of any symptoms that they may have. Reliever drugs or rescue drugs, those are used to stop an attack once it has started. So we have short-acting beta agonists, the SABA. They may be used as relievers, as reliever inhalers, and inhaled corticosteroid for Formoterol may also be used as a reliever inhaler in the treatment of asthma in adults. Bronchodilators are used to prevent inflammation, and box 24.3 addresses step therapy. With step therapy, drug therapy is prescribed at different levels, starting with step 1 and progressing upward until acceptable control is achieved. And when this is maintained for 3 months, the provider steps the drug down until good control is maintained at the lowest possible drug dosage. Table 24.1 lists the most common and preferred drugs in each class for control and relief therapy for asthma. Many inhalers are used, and the metered dose inhaler, the dry powder inhaler, and the soft mist inhalers are available for use. And spacers can be used with meter dose inhalers. Proper technique is so important for the medication effectiveness. So box 24.4 does have patient and family education, and that's on page 547. It's important to know. Bronchodilators cause bronchiolar smooth muscle relaxation, but have no effect on inflammation. So if patients have inflammation, at least 2 types of drug therapy is needed. And the bronchodilators include the beta-2 agonists and cholinergic antagonists. And the beta agonists bind to and stimulate the beta-2 adrenergic receptors in the same way that epinephrine and norepinephrine do. So this causes an increase in smooth muscle relaxation. And then we have short-acting beta-2 agonists, or SABA. They provide rapid but short-term relief. And these drugs are most useful when an attack begins as relief or as pre-medication when the patient is about to begin an activity that is likely to bring on an asthma attack. Examples of these drugs are albuterol. I know you're familiar with albuterol, levoalbuterol, and terbutaline. And then the long-acting beta-2 agonists are your LABAs, and they are delivered by inhaler directly into the bronchioles. Proper use decreases the need to use reliever drugs as often, and long-acting drugs may need time to build up the effect, but the effects are longer and they last longer, so they're lasting. And the LABAs are useful in preventing an asthma attack, but cannot stop an acute attack. So if wheezing is a symptom, teach the patient to use the SABA. Examples of LABA include formoterol and salmeterol. So both of these drugs are associated with increased asthma deaths when used as the only therapy for asthma, and they do carry a black box warning from the US FDA. And this is because they're not rescue drugs. You need 2 different types of drugs for your asthma attacks. They're long lasting and they prevent asthma attacks from coming on, but they are not rescue drugs. So see the drug alert box on page 547. Cholinergic antagonist or anticholinergic drugs or long-acting mucarinic antagonists or LAMAs. They are similar to atropine and block the parasympathetic nervous system. And this drug increases bronchodilation and decreases pulmonary secretions. So the most common drug in this class is ipratropium inhalant. So some cholinergic antagonists are short-acting and used several times a day. And then the long-acting agents such as tiotropium are used once a day. The methylenthines such as theophylline and aminophylline are used rarely when all of the other types of management are ineffective. So these drugs are given systemically, they're given IV, and the dose that is affected is very close to the dose that produces many dangerous side effects. So blood levels must be monitored to ensure the drug is in a therapeutic range. Your anti-inflammatory agents decrease airway inflammation, and the inhaled form have fewer side effects than those taken systemically. And you learned that in pharmacology. So the anti-inflammatory drugs are controller drugs. These drugs are not effective in reversing symptoms during an asthma attack, and they should not be used alone as reliever drugs. Nurses should teach patients to take anti-inflammatory drugs on a scheduled basis, even when no symptoms are present. And then your corticosteroids also decrease inflammation by reducing the production of inflammatory chemicals. Inhaled corticosteroids are the most effective anti-inflammatory medication for asthma. High-potency steroid inhalers such as fluticasone, budesonide, and mometasone are used once daily for maintenance, and some combination drugs include inhaled corticosteroids and inhaled beta-2 agonists such as ellipta, which is available in different strengths and is prescribed once daily. Systemic corticosteroids are avoided for mild to moderate intermittent asthma and are used on a short-term basis for moderate asthma because they do have severe side effects. Cromolyn inhaled agents are used as a controller therapy and taken on a scheduled basis. These reduce inflammation in airways by inhibiting the release of inflammatory chemicals such as nidocromil or preventing mast cell membrane from opening when an allergen binds to IgE, such as cromolyn sodium. And the leukotriene modifiers are oral drugs that control asthma when taken on a scheduled basis. And examples of this are montelukast and zafirlukast, which block the leukotriene receptor. And then xylutin prevent leukotriene synthesis. And monoclonal antibodies are the newer drugs specifically for the management of airway inflammation. And categories that include the IgE antibody antagonist omalizumab, that's an interleukin 4 receptor antagonist, that's the dupilumab, and the interleukin 5 receptor antagonist benralizumab, and mepolizumab, and rizolizumab. So all of those drugs are the montelukast category. None of these drugs are first-line agents to manage acute asthmatic episodes. So the drugs are big. There's a lot of drugs. But again, I've made a grid for you. There's a table in your book, and I know you can do this because you've probably already been exposed to these drugs in your pharmacology class. Regular exercise is recommended for asthma therapy to maintain cardiac health and strengthen muscles and promote gas exchange and perfusion. Clients and patients should know their triggers for asthma attacks, and some may need a SABA before exercise. Some patients may need indoor versus outdoor activity during some seasons. Supplemental oxygen by mask or nasal cannula is used during acute asthma attacks. High-flow delivery may be needed when bronchospasms are severe and limit the flow of oxygen through the bronchial tubes. We need to remember that oxygen is flammable. We've talked about this before. You've had this in your labs when we're going over oxygen, the types of oxygen administration. So I know you know all this. So that just use what you know about the hazards of using oxygen. We know that oxygen is flammable, so no smoking is allowed when the patients are using oxygen. We don't want the oxygen to be in the same space as fireplaces, or we don't burn candles or other combustible hazards. We don't have other combustible hazards in the rooms when we're using oxygen. We don't even use petroleum products like for lip balm or anything like that. We don't use Vaseline. We don't use any of those because it could burn the patients. Status asthmaticus. I mentioned this earlier when I spoke of the young 30-something-year-old man that passed away and left his young son and his wife about 15 or I don't know, close to 20 years ago, I guess. Um, but this is a severe event. It's life-threatening. It is an acute episode of airway obstruction that intensifies once it begins and often does not respond to the usual therapy. And this scenario usually begins with the patient presenting to the emergency department with extremely labored breathing and wheezing. And the use of accessory muscles for breathing and the distension of neck veins are visible in these cases. If this condition is not reversed, the patient may develop pneumothorax or a collapsed lung and cardiac or respiratory arrest. Treatment includes IV fluids, potent systemic bronchodilators, steroids, epinephrine, oxygen, and all of this is given immediately to reverse these conditions. Preparation for emergency intubation may be needed as well. A sudden absence of wheezing along with a low oxygen saturation indicate complete airway obstruction, and this requires a tracheotomy. So when breathing improves, the treatment would be similar to that for a regular asthma attack, but all of this is so intense and it's life-threatening. So we need to be thinking about status asthmaticus, and how that would be treated and how we as nurses need to respond. Chronic obstructive pulmonary disease, COPD. This is a collection of lower airway disorders that interfere with airflow and gas exchange. And these disorders include emphysema and chronic bronchitis. Although these are separate disorders with different pathologic processes, many patients with emphysema also have chronic bronchitis. Emphysema is a destructive problem of lung elastic tissue that reduces its ability to recoil after stretching, and it leads to hyperinflation of the lung. These changes result in dyspnea with reduced gas exchange and the need for an increased respiratory rate. So primary emphysema is linked to a decrease in the enzyme alpha-1 antitrypsin, and this is an inherited disorder suggested in patients who do not smoke or develop the disease before the age of 40. And the major cause of secondary emphysema is cigarette smoke. So other contributing factors include air pollution, occupational exposure, and respiratory infections in childhood. In the healthy adult, enzymes called proteases are present to destroy and eliminate particles inhaled during breathing. Cigarette smoking triggers increased synthesis of these enzymes to higher than normal levels, which damage the alveoli and the small airways by breaking down the elastin in the lungs. So over time, the alveolar sacs lose their elasticity or the ability to recoil, and these small airways collapse and they narrow. and some alveoli are destroyed and others become large and flabby, and they have less area for the gas exchange to take place. So that's what happens with the emphysema. So then we have chronic bronchitis. This is an inflammation of the bronchi and bronchioles, and this is called bronchiolitis. And this is characterized by increased mucus and chronic productive cough for at least 3 months of the year for at least 2 consecutive years. And the cause is inspired irritants, especially cigarette smoke. The irritant triggers inflammation, vasodilation, mucus, mucosal edema, and congestion and bronchospasms. And the thick mucus and narrow airways lead to air trapping of air in the alveoli, and the chronic inflammation increases the number and size of the mucus secreting glands, which produce large amounts of thick mucus. And the bronchial walls then thicken, and then that impairs the airflow. The mucus further narrows the airway and also provides a breeding ground for organisms that lead to infection. And this all results in a lowered PaO2 or hypoxemia, and the arterial carbon dioxide, the PaCO2 level increases, and this is respiratory acidosis. So, as I said, cigarette smoke is the greatest risk factor for COPD. The patient with a 20-pack year history or longer often has early stage COPD with changes in pulmonary function tests or PFTs. With this process of damage from the cigarette smoking, the inhaled smoke triggers the release of excessive proteases in the lung, and these enzymes then begin to break down the elastin, which is a major component in the alveoli. The smoke also impairs the cilia in the lung from clearing the bronchi of mucus and cellular debris and fluid. Alpha-1 antitrypsin deficiency is a less common but important risk factor for COPD, and this is often unrecognized. This enzyme, alpha-1 antitrypsin or AAT, is normally present in the lungs and inhibits excessive protease activity. Normally, proteases only break down inhaled pollutants and organisms and do not damage lung structures. About 100,000 Americans have severe AAT deficiencies. This deficiency causes problems in the skin and liver, and lung diseases are common. And I want you to look at the genetics genomic box on the top of page 550. In addition to genetic and environmental factors, asthma is considered a risk for COPD. COPD is reported 12 times more often among adults who are diagnosed with asthma. And there's also asthma COPD overlap syndrome. And there are approximately 15.7 million Americans and over 800,000 Canadians report having been diagnosed with COPD. Excuse me. An estimated death rate is about 3 million annually worldwide, and it is estimated by year 2060 that over 5.4 million deaths will occur annually from COPD. So this is a major, major issue. COPD impacts the gas exchange of individuals at the cellular level, and complications do include hypoxemia, acidosis, respiratory infections, cardiac failure, dysrhythmias, and respiratory failure. How does hypoxemia occur? Hypoxemia, as well as acidosis, occurs because of reduced gas exchange, which leads to decreased oxygenation and increased carbon dioxide levels. And these problems reduce cellular function in the body. Respiratory infection risk increases because of the increased mucus and poor gas exchange. Bacterial infections are common, and make the COPD symptoms worsen because of the increasing inflammation, the mucus production, and inducing more bronchospasms. Airflow becomes more limited, and the work of breathing increases, and dyspnea results. Cardiac failure, especially cor pulmonale, and this is right-sided heart failure caused by pulmonary disease. This occurs with bronchitis or emphysema. Air trapping, airway collapse, and stiff alveolar walls increase the lung tissue pressure and narrow lung blood vessels, making blood flow more difficult. The increased pressure creates a heavy workload on the right side of the heart, which pumps blood to the lungs. And in order to pump blood through the narrowed vessels, the right side of the heart generates high pressures. In response to the heavy workload, the right chambers of the heart enlarge and then they thicken, causing right-sided heart failure with backup of blood into the general venous system. I want you to look at box 24.5 for the features of cor pulmonale. That's on page 550, and I want you to know that. And the cardiac dysrhythmias are common in the patients with COPD, and they result from hypoxemia or from decreased oxygen to the heart muscle. Other cardiac diseases and drug effects are also the cause. Sometimes the cause also acidosis. So early diagnosis is so important to begin the management of COPD and could change the course and progression. Pulmonary function testing is needed for confirmation of COPD. However, the disorder should be suspected in any patient who has dyspnea, chronic coughing, or sputum production, recurrent lower respiratory infections, and or a history of particulate matter exposure. And that's a mixture of tiny solid and liquid particles suspended in the air, varying in size, shape, and chemical composition. So the risk factors include age, sex, and occupational history. COPD is seen more often in females and those 65 and older. Some types of emphysema occur in families, especially those who have AAT deficiency, and we need to obtain a thorough smoking history. Need to know if they vape, if they're vaping. Asking the patient about respiratory problems is a must. Do they have shortness of breath while talking? Does the patient speak in complete sentences? So we need to ask about wheezing, coughing, shortness of breath, and determine the triggers that bring on these problems. If the patient is producing sputum, we need to ask about the color of the sputum, how much and how often it occurs, and ask about activity level and shortness of breath compared to a month ago and a year ago. And then we need to ask about difficulty eating and sleeping. Are they having worsening breathlessness while lying down? And if they're having breathlessness while lying down, that is called orthopnea. And ask the patient about their ability to perform their ADLs. A current weight is necessary and compared to previous weights. And then we have unplanned weight loss. That's likely when COPD severity increases because of the work of breathing and increases in metabolic needs. And when heart failure is present with COPD, in general, edema and weight gain may occur with that. We need to note that a dietary recall may be needed. Look at their general appearance too. We always say the patient in front of you, look at that. Look at the proportion of their body height and weight and their posture, their mobility, their muscle mass, and hygiene. And the patient with increasingly severe COPD, they will be thin. They will have loss of muscle mass in their extremities. They will be slow moving and slightly stooped. And the patient often sits in a forward bending posture with the arms held forward and that posture is known as orthopnic or tripod position. So with increasing dyspnea, hygiene may be neglected too, and that's another sign of illness. The illness is worsening. The respiratory changes related to obstruction include fatigue and changes in the chest size. During acute exacerbations, respirations could be 40 or 50 per minute, which requires immediate medical attention. As respiratory muscles become fatigued, respiration movement becomes jerky and or uncoordinated, and the we need to assess the patient for retractions and asymmetric chest expansion. The patient with emphysema will have limited diaphragmatic movement because the diaphragm is flattened and below the normal resting state. The chest vibration or fremitus, y'all learned about fremitus when you did your physical assessment training, and this is decreased, and the patient's chest sounds are hyperresonant or percussion because of the trapped air. So you will hear wheezing and other abnormal breath sounds upon inspiration and expiration. Crackles are usually not present with this scenario. Reduced breath sounds are common, especially with emphysema. A silent chest may represent serious airflow obstruction or a collapsed lung or what we call pneumothorax. That is a collapsed lung. And the client may present with that barrel chest that we talked about. And I gave you the parameters and the ratio of those. And then a visual analog dyspnea scale, or VADS, is useful. The scale is used to determine therapy effectiveness and the pace of the patient's activities. And the patient with chronic bronchitis usually has a cyanotic or blue tinged, dusky appearance and excessive sputum production. Also, what about the nails? Sometimes the fingers exhibit clubbing, which indicate chronically decreased arterial oxygen levels. So the fingers will look clubbed. They'll have a certain appearance to them. I'll try to get a picture of that for you. And then the psychosocial assessment, the patient may be isolated because of the dyspnea that causes fatigue or because of embarrassment from coughing and excessive sputum production. The nurse can ask about the patient's hobbies and interests and assess if their socialization has decreased and if hobbies cause exposure to irritants with them. Assess their living conditions. Are they in smoke-filled rooms or homes or crowded living conditions, which may promote respiratory infections? And then they may have anxiety and fear related to breathlessness, so that could be a factor as well. So this is your visual analog dyspnea scale. So we may use this with our patients who have COPD. And there are laboratory assessments that we need to pay great attention to, and these include the arterial blood gases, the ABG values. Compare the baseline ABGs to the continued ABGs. Your pulse oximetry can gauge the treatment response. And as COPD worsens, the amount of oxygen in the blood decreases, and that is hypoxemia, and the amount of carbon dioxide increases, and that is called hypercapnia or hypercarbia. The chronic respiratory acidosis then results, and this is increased arterial carbon dioxide. And then we may have a metabolic alkalosis, which is increased arterial bicarbonate that occurs as a compensation by the kidney retention of bicarbonate. Hypercapnia is often chronically present in advanced emphysema. Sputum samples are obtained for culture and when they're hospitalized, and they have an acute respiratory infection. So hemoglobin and hematocrit determine polycythemia or a compensatory increase in red blood cells and iron in the chronically hypoxic patient. Your serum electrolyte levels are studied because acidosis can change the electrolyte values. And then you have low phosphate, potassium, calcium, and magnesium levels that reduces the muscle strength. And your chest x-rays are used to rule out other diseases and to check for hyperinflation with advanced emphysema. And with this, you'd have, excuse me, a widely spaced ribs and flattened diaphragm. To classify the severity in indications based upon symptoms, the COPD assessment test or CAT is an 8-item test in where the patient rates specific symptoms on a scale of 0 to 5. And scores range from 0 to 40 and reflects symptom severity, and these are used as an indicator of the risk for exacerbation. And then you have your peak expiratory flow meters, and they're used to monitor the effectiveness of the drug therapy. And I also have a video that we'll use in class to see how a peak flow meter is used to show you that in class. And so the priority collaborative problems for patients with COPD are decreased gas exchange related to physiologic changes in the respiratory system. We also have weight loss related to decreased intake associated with dyspnea. Also fatigue related to an imbalance between oxygen supply and demand. And then we have potential or risk for pneumonia or other respiratory infections. Excuse me, I'm going to get a little bit something to drink. I have the pollen that's bothering me this week. Okay, so the patient with COPD is expected to attain and maintain gas exchange at the patient's baseline level, and the interventions include ensuring consistent use of prescribed drug therapy and on airway maintenance, monitoring breathing techniques, positioning, effective coughing, O2 therapy, exercise conditioning. We also have suctioning and hydration. And the nurse should assess breathing rate, rhythm, depth, and use of accessory muscles prior to all therapy. The airway maintenance is most important to focus on interventions to improve gas exchange. Drug therapy is recommended to delay the progression and promote continued activity tolerance. The same drugs used for asthma are used to manage COPD patients, and they are beta adrenergic agents, cholinergic antagonists, methylxanthines, corticosteroids, and cromolyn. The focus is on long-term controlled therapy with longer-acting drugs, such as arformoterol, indacaterol, tiotropium, aclinidium, bromide, olodaterol, and combination drugs such as fluticasone, vilanterol, or Brio ellipta, and then the triple combination of fluticasone, umetaquinone, and vilaterol. That triple combination is called Trilogy ellipta, and the inhaler use requires the correct technique, and we'll look at that correct technique in class. And the initial demonstration and return demonstration at every outpatient interaction is so important to reinforce the correct technique, because it does take a while for patients to realize if whether or not they're doing this right. But it's so important for the therapy, for the effectiveness of the therapy. So we need to help the patient acquire the knowledge and skill necessary with that. The COPD patient requires systemic agents in addition to inhaled agents such as mucolytics, which decreases the thick secretions, making it easier to cough and expel these thick secretions. And guaifenesin is a systemic mucolytic taken orally. Acetylcysteine is an inhaled mucolytic used with normal saline in a nebulizer. And so a combination of guaifenesin and dextromethorphan raises the cough threshold. The stepped therapy, which adds drugs as COPD progresses, is recommended for patients with chronic bronchitis or emphysema, and the patient's response guides the drugs and the dosage changes of the drugs. And so drugs are stepped up with exacerbations and stepped down with stable symptoms over time. And the ordered O2 could be applied as assessing the patient's response to therapy and the focus on prevention of complications. And so the patient's condition would be categorized as worsening if a sudden sharp rise in CO2 or severe decrease in PaO2 is measured. And in this case, more aggressive therapy would be needed. Non-invasive ventilation, NIV, may be useful for patients with stable, very severe COPD, daytime hypercapnia, and is preferred over invasive mechanical ventilation or intubation. Though invasive mechanical ventilation may be needed for clients in respiratory failure if they are unable to tolerate or unresponsive to the non-invasive ventilation. So breathing techniques such as diaphragmatic or abdominal and pursed lip breathing is used for managing the dyspneic episodes. And I need to ask you to see box 24.6. Know these two techniques. It's on page 554. And so we're going to teach these techniques when the patient has less dyspnea so they can use it in times of increased dyspnea. And then positioning, we need to have the patient remain upright with the head of the bed elevated. Have the patient who is able to get out of bed and sit in the chair for 1 hour, periods 2 to 3 times a day. And then effective coughing, this helps increase airflow in the larger airways. So COPD patients do have a harder time removing those secretions, resulting in poor gas exchange. And the excess mucus increases the risk of infections there too, because they harbor the infections and create a good medium for growth. So we need to look at that technique on page 554. And so we will talk about a little bit about lung transplants, but that usually is it takes a long time and not every patient is a candidate for that. So, but we'll look at that in class. Readmissions, morbidity, or mortality for patients with COPD are common occurrences, and most patients are cared for in the ambulatory care setting and cared for at home. And action plans are created to reduce exacerbations and should include reinforcement of appropriate medication and teaching clients to recognize the need for early medical intervention. So for patients with advanced disease, 24-hour care may be needed for ADLs and monitoring, and placement in a long-term care facility may be needed. So I need you to pay great attention to box 24.7 on page 558. And then these are the expected outcomes of care for the COPD patient. and I will let you read those yourself on your own, but we will go over these in class. And then this is the GOLD classification of chronic obstructive pulmonary disease severity. We have GOLD 1, GOLD 2, GOLD 3, and GOLD 4. And the definition is on the right side. It gives you the FEV1 percentage of predicted function, and for each of those. And so for 1, it is 80%. For 2, it is 50%. For 3, it is 30%. And for 4, it is less than 30%. So this is on table 24.2, page 552. So I need you to look at that. And PAH is not a form of COPD, but PAH can be a complication of COPD. Pulmonary hypertension is the chronic increase of pulmonary vascular pressures above 25 millimeters of mercury, which makes the right side of the heart work much harder for lung perfusion to support adequate gas exchange. Normally, the pulmonary vascular pressures are low, 15 to 18 millimeters of mercury, allowing for the pressures generated by the contraction of the less muscled right ventricle to easily overcome them and move blood into the pulmonary artery. But over time, the higher lung vascular pressures lead to right-sided heart failure or cor pulmonale, which may be fatal. COPD and pulmonary fibrosis can cause a secondary increase pulmonary pressure, and good control of the condition causing this can delay or prevent cor pulmonale or right-sided heart failure. So primary pulmonary artery hypertension, also known as idiopathic pulmonary artery hypertension, is a condition where pulmonary vessels and other lung tissues undergo growth changes that greatly increase pressure in the lung circulatory system for unknown reasons, and this progresses to cor pulmonale with reduced perfusion and gas exchange. And the cause is unknown, and its diagnosis is it is diagnosed in the absence of other lung disorders. Genetic and environmental factors may work together to increase the risk, and exposure to fenfluramine or phentermine and dexphenfluramine, which are drugs used to suppress appetite, increases the risk. So you do have some drugs that were put on the market approximately 15 to 18 years ago that are only supposed to be used for short periods of time. And if patients overuse these or use them incorrectly, use them too long, they could develop this pulmonary primary pulmonary artery hypertension, and it could impact their health really to be a really poor health condition that they could have to live with the rest of their life. So it's very important that your patients realize that risk when they're trying to lose weight and they're trying to use those drugs to lose weight. This type of exposure of these drugs and this development of the pulmonary hypertension, that they occur mostly in women between ages 30 and 60. Death usually occurs within 2 years after the diagnosis, most often from heart failure, and it is often diagnosed late in the disease process. So that's that creates a poor prognosis there. So if there are first-degree relatives in the patient's family who have been diagnosed, to have regular health checks and to to consult primary health care providers whenever pulmonary problems are present. So because it can be not hereditary per se, but people with sensitive lungs can be susceptible to the same problem. So we need to look out for that. Okay, so this is a case study that we're going to look at in class. I'm not going to go into it too much here because we are going to go into it in class. And we have some questions that we'll review in class. And the answers to the questions we'll review. We'll also play a beach ball game with our medications. We want to get to know our medications really well. And so we'll have some time where we'll have a little bit of fun with that beach ball and possibly have some prizes for correct answers of the beach ball questions. And so the next thing we'll look at some patient and family education as well. And then we'll turn to RSV and bronchitis. And on Saunders, page 453, chapter 36, we look at bronchiolitis and respiratory syncytial virus, or RSV. This is an inflammation of the bronchioles that cause production of thick mucus that occludes the bronchial tubes and the small bronchi. And RSV causes an acute viral infection and is a common cause of bronchiolitis. Other causes include adenoviruses and parainfluenza viruses and human metapneumovirus. And RSV is highly communicable. It is usually transferred via droplet by direct contact with respiratory secretions. So it's important that you realize RSV is a droplet contagion. RSV occurs primarily in the fall of the year, winter of the year, and spring. RSV can be contracted at any age, but it typically causes the most problems with respiratory distress in children younger than 6 months of age. At-risk children include those who have a chronic or disabling condition and those who are immunocompromised, and the identification of the virus is done via testing of nasal and nasopharyngeal secretions. Prevention measures include the encouragement of breastfeeding because the baby gets all of those important antibodies from the mom. Also, the avoidance of exposure to tobacco smoke and the use of good hand washing techniques because, as I said earlier, we can carry this RSV back to our babies unknowingly. Also, administering Pembrolizumab, a monoclonal antibody, to high-risk infants can be helpful. The assessment of for babies with respiratory syncytial virus, the babies will have rhinorrhea, eye or ear drainage, pharyngitis, coughing, sneezing, wheezing, intermittent fever, and manifestations as disease progresses include increased coughing and wheezing, signs of ear hunger, nasal flaring, tachypnea, and retractions, and periods of cyanosis. And this, of course, is a bluish tinge around the mouth and the nail beds. And manifestations in severe illness include tachypnea of more than 70 breaths per minute, decreased breath sounds, and poor air exchange, and listlessness, just like a a baby is kind of like a dishcloth falling around, their listlessness. And the apneic episodes, they stop breathing. And then their pulse ox drops really low. And this is so scary. Um, and so the interventions are aimed at treating the symptoms and include airway maintenance, cool humidified air and oxygen, adequate fluid intake, and medications. And for a hospitalized child with RSV, we would place the child in a single room to prevent transmission of the virus, and we would ensure that nurses caring for a child with RSV do not care for other high-risk children. And we would use contact droplet and standard precautions during the care. We would use good hand washing techniques as necessary, and monitor airway status and maintain the patient's patent airway. For effective airway maintenance, we would position the child at 30 to 40-degree angle with the neck slightly extended to maintain an open airway, and then we would decrease the pressure on the diaphragm. We would provide cool humidified oxygen as prescribed by the provider and monitor the pulse oximetry levels, probably constantly in the acute phase, and then encourage fluids. IV fluids may be necessary until the acute stage has passed. We would have periodic suctioning that may be necessary if the nasal secretions are copious, and we may use a bulb syringe for suctioning of the infants at home. If the child is hospitalized and the bulb syringe is ineffective, a nasal aspirator with attached mild to moderate wall suction may be used. And then we would suctioning would be done before feeding to promote comfort and adequate intake. Antiviral medication may be prescribed as well. So I do have a video that we hopefully will have time to watch. And then I have some practice questions. So we'll do the practice questions in class. I appreciate your attention to this video. I hope it's helpful. And I apologize for my breathing issue tonight from the pollen effect outside, because the pollen is everywhere. But I hope to see you soon, and we'll have fun in class. Thank you.